Hello, let us discuss about the respiratory system, not completely though, only few important aspects. But first of all, just remember that you need to study what's everything. You have to study everything, but remember what's necessary. So, this is the main motto that you should have. So, coming on to the basics of respiratory system, we'll deal with the maximum 90% physiology, okay, and applied aspects. Okay, so we'll try to cover it in 20 to 25 minutes. So we'll be just a little quick about the discussion. Yeah, moving on to that. So in order for the lungs to get filled with air, it needs some pressure gradient, right? Usually when it's in equilibrium, we consider the atmospheric pressure to be zero. So in equilibrium, atmospheric pressure is equal to alveolar pressure. So it is zero. In order for air to enter into this lungs, alveolar pressure must go to negative, right? So it should be negative. Only then it pulls the air from outside to inside. Okay. For intraalveolar pressure to be negative, there must be a force which pulls the alveoli or distance the alveoli, right? See, in this area, this is the pleural space, there is fluid that's called pleural fluid, right? This pleural fluid connects the chest wall to the the parietal pleura to the visceral pleura, that is chest wall to the lungs. Okay, in order to maintain this connection, there is pleural fluid. This, when chest wall expands, the intrapleural pressure becomes negative, and this pleural fluid also connects the lungs to the chest wall, and also it decreases the pressure. It tries to expand the lungs. Okay, it tries to expand the lungs, thus decreasing the pressure in alveoli. Okay, here, and the air moves in. Air moves in up to what point? Up to atmospheric pressure is equal to okay, intraalveolar pressure. That is good. So that means up to equilibrium it will move. So what is this, sir? It is intraalveolar pressure, that is pressure in alveolus. It is usually zero, okay, at rest, and in inspiration it becomes negative. Intrapleural pressure, it is usually negative. Why negative? So if the alveoli and the lung tissue has a tendency to collapse, right, which is being prevented by the surface tension caused by the surfactant and also the intrapleural pressure. This intrapleural pressure, it is negative because of the chest wall, and it tries to keep the lung expanded and preventing it from collapse. So it should be negative, and hence it is negative. Okay, what if this becomes zero? It will happen when? What if it becomes zero? That means it is equal to the atmospheric pressure, then the lung will collapse. So this term, this intrapleural pressure and alveolar pressure, preventing the lung from collapse, it is the difference is given by this transpulmonary pressure. Okay, this is intraalveolar pressure minus intrapleural pressure. Okay, it is usually positive. Why? Because here you are considering as if the lungs and the air is exerting the pressure on the lungs. Okay, the air is exerting pressure on the lungs from inside to maintain the patency and keep the lungs open. So this is how it is called positive. Usually in normal at rest state, at rest it is +2, okay, +2 mmHg, whereas at inspiration it has to increase, right, because the air is entering, so it is +6. Okay, if the transpulmonary pressure is 0, that means IAP is equal to I into IPP. That means it's a case of what? Open pneumothorax, because IAP is equal to atmospheric pressure and IPP is also equal to atmospheric pressure, that is 0. Okay, 0 minus 0 is 0. That is a case of open pneumothorax. In case of open pneumothorax, the transpulmonary pressure is 0. Okay, then there are different curves to plot it, this compliance and pressure differences, that will not go into so much depth. And the closing volume, right? See, you know that there are few volumes of the lungs in the spirometry given in single nitrogen breath washout test, etc. Okay, and DCLO. So this closing volume, when the lung, you're breathing air and breathing out the air, right? So if you want some air to remain in the lungs, okay, some air to remain in the lungs, it has to be trapped inside. Okay, this remaining air, residual volume, residual air, how it's trapped? Okay, how is the residual air trapped, and what is the use? Residual air should be trapped in order to maintain the patency and preventing the lung to collapse. For example, take this as a terminal or respiratory bronchiole. This is the alveoli. Okay, so when you are expiring, when the expiration is going on, the pressure is exerted from every side of the alveoli towards the center, isn't it? It's your natural tendency. When you compress a balloon, from all the sides, the pressure will be maximum at the center. It is towards the center. So in this case, at one particular volume x, okay, remember, at one particular volume x, this airway, that is the respiratory bronchiole, is compressed completely and obstructed because it's towards the center. Okay, it is compressed, it is closed, and the remaining air is trapped inside. Okay, this volume is called closing volume. Okay, the volume at which first airway close in the dependent parts of lungs. Okay, this is the dependent part, right? Because the bases are the dependent when you are standing, and when you are sleeping, the dependent parts are the posterior surface of the lung, posterior area. Okay, like that, when the volume at which the first airway close in the dependent part of the lungs, okay, this is called closing volume. And the closing capacity, this is closing volume Cc is equal to closing volume plus reserve volume or residual volume. This is very important. Residual volume, it will be there in the lungs no matter what. How much you try to expire the air, it will not go. Okay, this is the basic thing. And coming to the different volume definitions, we'll not brag a lot about this, we'll just be very quick and thorough. Okay, as we are seeing here, it is tidal volume. Tidal volume is a normal quiet inspiration to a normal quiet expiration. Okay, normal inspiration, normal expiration. Very good. This is the tidal volume, and the physiological changes and the other changes you should know. And apart from that, we'll move to the next inspiratory reserve volume. Inspiratory reserve volume is extra volume breathed in above tidal volume. That means after normal inspiration and expiration, how much you can breathe in. See, you're taking some amount of air normally, usually when you're sitting, but you're taking an extra amount of air after breathing in normal amount. Okay, and we'll look at this in a graph form, don't worry. So in expiratory reserve volume, this is normal quiet expiration to maximum expiration. So after normal inspiration, you are breathing out in normal expiration, and then after normal expiration you are breathing out more air forcefully. Okay, so this is expiratory reserve volume, this normal quiet expiration to maximum expiration, and residual volume remaining air after maximum expiration, right? This cannot be measured on spirometry because something which is inside and is not coming out, so the spirometer cannot pick it up. Okay, next, see the volumes and capacities. There's a small difference. As we are seeing here, capacities are composites of two or more lung volumes. Okay, they are fixed, do not change with pattern of breathing. See, so this is why capacities are very important to diagnose different diseases and different conditions of the lungs. Fine. And coming to that vital capacity or forced vital capacity. See, maximum inspiration to maximum expiration. So you are taking in maximum inspiration and then you are giving out with maximum expiration using the accessory respiratory muscles for both inspiration and expiration. Okay, for this to happen you require good compliance, right? That is what he said. See, it requires good adequate amount of compliance and the force of muscles to work. Okay, very good. And inspiratory capacity, quiet expiration to maximum inspiration. Okay, you have expired after tidal volume, you have expired, and then you are now inspiring maximally. Okay, this is inspiratory capacity. How much you can inspire after normal expiration is the inspiratory capacity, because expiratory reserve volume does not count, because it is the reserve volume after expiration that may be used when you are holding breath. You are not dying immediately. There is some amount of oxygen that is being exchanged in the alveoli, that is from the residual and expiratory reserve volume, right? Good. Then functional residual capacity, the volume remaining after quiet expiration. Okay, quiet expiration, that is the functional residual capacity. That is you are functioning with it when you are holding a breath after normal expiration. You are not dying immediately even though you don't inspire. That is due to functional residual capacity, right? And next is total lung capacity. Total lung capacity is all the volumes together. Okay, that is all the sum of all volumes. Usually it is 6 liters as we have seen. Okay, and remember this, in restriction or restrictive lung diseases it is less than 80% of the normal, and hyperinflation it is more than 120. Hyperinflation syndromes is emphysema, right? Okay, next, see, this is measured with helium dilution because you need to get the reserve volume, right? Good. See, this cannot be measured in spirometry, the reserve volume, so you need helium dilution method. And there are two spaces, dead spaces, anatomical and alveolar. Simple thing, it is very simple to remember. Air that never reaches the alveoli is anatomical dead space, and air that reaches alveoli but never participate in respiration is alveolar dead space. Okay, good. That may be due to many reasons, that is not participating in respiration, maybe like decreased perfusion or so. So this is the graph we have been talking about, and here are the volume curves. See, this is usually the tidal volume, right? See, this is the tidal volume, normal inspiration, normal expiration. See, that is what here, the tidal volume. And after normal inspiration, how much more you can breathe, This is the, what is this? This is the inspirator reserve volume. Okay, you got it? And expirator reserve volume is after normal expiration, how much you can more expire, right? Very good. And coming to the residual volume, which you cannot measure on spirometry. Good. So this is helium dilution method. Very good. Next to the inspiratory capacity, normal expiration to maximal expiration. See here, that is what the graph is showing. Normal expiration to maximal inspiration, right? That is inspiratory. That is the capacity of you breathing your air inside. Okay, and this is functional residual capacity. You know, as I told, you don't die immediately after expiring, normal tidal expiration. Okay, and this is vital capacity, because that is what that can be measured on spirometry. This is important. And residual volume, it cannot be measured. You can take it as anything that can, all the volumes that that can be measured on spirometry together forms vital capacity of the lung. Okay, or simply tidal volume plus IRV plus ERV. Okay, very good. So this is the total lung capacity, which requires two techniques to measure it. One is spirometry, that is vital capacity, and other on helium dilution method. So these two methods combined only can measure the total lung capacity. It is the same here also, everything. So you can just take a screenshot of this or this. Okay, next. See, normally we'll plot a simple graph, because respiratory system and the lung volumes are mostly graphs. Okay, this simple graph will do many miracles, or we'll plot it here. So for pressure, let us take this red one as pressure. Okay, this red is pressure. Initially at inspiration the pressure decreases, while expiration the pressure increases, right? You are putting force to expiration. Yes, good. You are pulling the lungs, the negative pressure. This is positive, right? This is the pressure, and followed by that the volume. Let us take this blue, this violet one as volume violet. Okay, usually what happens is it is never negative, so there is an increase in the volume during inspiration, right? Everyone can say, even an LKG student. And there is a gradual decrease in the volume in expiration, right? Very good. And followed by that, and you have intrapleural pressures. Yes, you'll take it as, you'll simply use green for intrapleural pressure. See, it is simple. Here the intrapleural pressure is usually negative, normally negative. So inspiration it becomes more negative, and expiration it becomes less negative. Okay, intrapleural pressure -6, it is usually -2 normally, and here again -2 at rest. Fine, that is good. So if you take this upside, you know, this what do you call that, this intrapleural pressure upside, and you plot it, what will happen? And you reverse it, that means you'll change the color. If you change it, it is usually +2 +6 +2, right? +2 +6 +2. This is TPP, transpulmonary pressure. You get it? It's simple, so simple. The same thing we'll see in this graph. See long volumes. You're seeing, right? The lung volumes. Normal expiration, normal inspiration, and the alveolar pressure more negative and more positive. And then the intrapleural pressure, it is usually negative and then usually more. That's good. Okay. And followed by that, this compliance is very simple thing actually. Okay. The ability to expand. The compliance is ability to expand. That is the simplest definition you can give. Okay, out of many things, see the chest wall, you can compress this, right? You can do more compression, more and more, right? The chest wall. But lung compliance is limited. I mean, it cannot be completely compressed because of the reserve volume and the residue. I mean, that is the residual volume or the reserve volume or the surface tension due to surfactant. So it is usually stopped and stable at one point. Fine. And the mean is taken as lung chest wall net compliance. This is very good. So if you take this as the normal compliance, let us plot a graph, which is important. So if you take this as normal compliance, right, there are two things, usually shifts up or down. So what happens usually, that means what is happening to the compliance? This is change in volume, right? And this is change in pressure. Okay, with less pressure there is more increase in the volume here, isn't it? With less pressure, sorry, I plotted it reverse, and this is delta pressure, delta, I again did the same. Okay, with less pressure there is more increase in the volume. And see the second scenario here, with lot of pressure also there is less change in the volume. That means here the expansion has decreased. Here the expansion has overwhelmed, and here it is normal, isn't it? So if the expansion is decreased, you can say that something is restricting to it. Something is restricting. Okay. And here if the expansion is overwhelmed, you can say that the air is being trapped inside and is not coming out, right? It is the case of emphysema. Emphysema or air trap. Okay, good. This emphysema and air trap, this is a simple thing I'll tell you. In this graph, remember it as emphysema, and in restrictive lung diseases, RLD, the graph is right, low and down. Okay, remember this. This is simple. This is the better way you can remember it if you don't remember the concept, but I suggest you to remember like this, because I suggest you to remember like with the concept, because it is easier to solve any question or any case scenario in practical. Here emphysema, the graph flies. See here it's flying up, right? Good. And here RLD, right, low and down. Very good. And we'll move on to a simple more interesting concept, that is forced vital capacity. See, in this you have to read the definition as it is. So we'll see. It is the amount of air that can be forcibly exhaled from lungs, of course lungs, after taking deepest breath possible, right? Good. It is measured by spirometry. Remember this. This is measured by spirometry. This test helps you distinguish between obstructive lung diseases such as asthma and COPD and restrictive lung diseases such as pulmonary fibrosis and sarcoidosis. So you'll consider a simple graph here. See, let's plot a graph with these attributes. So usually what happens? This is, for example, you have taken deepest breath possible. Okay, this is the point. You have started expiration, right? So you can also practically experience this. After you take a deep breath and you breathe out forcibly, in the first, whatever the amount of air you breathe, okay, in the first, whatever the amount of air you breathe, this will always be maximum, isn't it? So in the first few a few seconds of time, you can say, actually that is 1 second, it will be maximum. So 1 second you will breathe out this much air, okay, and after that you will gradually breathe out some air, the remaining air. So at 1 second, this is called FEV1, and second FEV2, and the third second and is FEV3, right? So this is the concept. The maximum air you will breathe out in first second is FEV1, the amount of air. Usually, normally, remember this, normally this is 70%, minimum of 70%, a minimum of 70% of total air that you breathe out. Okay, good. So this FEV1 is important. Okay, this last point, what is it called? Forced vital capacity, FVC, the total air that you breathe out. Okay, very good. So what do you find that if in case there is an obstruction or a restriction, what is happening? We'll see about this. Lung disease, obstructive, restrictive. What are the things that are happening and what's going on here? In obstructive, like emphysema, you can take bronchial asthma. Deepest inspiration, you cannot breathe out much, right? So FEV1 will decrease, and FEV1 to FVC ratio will decrease, percentage will decrease, right? But here see, FEV1 will decrease, but FEV1 to FVC ratio or percentage will increase. Why? See, the total amount of air you are breathing in, so the maximum amount of air you have to take, but there is a restriction to the lung because of the disease. So the FVC is compromised. The FVC is compromised. When the denominator is decreasing and the FEV1 is negligibly decreasing, that means FEV1 ratio is increasing. Okay, this is the concept. Once again I am repeating, the numerator is decreasing, but the denominator FVC is decreasing far more than the numerator, right? So the ratio or percentage will increase. See here, obstructive, restrictive, and normal. See, actually this concept, this is a very good concept actually. The volume loops, okay, in this normal volume. So what is a volume loop? We'll see that. Here, when you are breathing air, see, normal, okay, expiration, normal expiration, you are breathing out air, and then you are coming to 0, and then normal inspiration, it is very symmetric, the pressure changes. Okay, this is pressure volume loop. The pressure changes are symmetric in inspiration, asymmetric in expiration. Okay, and see the graphs, this, just remember this, this is obstructive, this is the obstructive graph. There is a lot to discuss here, but I don't think it is the concept of discussion for pressure volume loops. We'll take this as a mini session. And here the restrictive, this is the restrictive class. This is simple, because see, the volume here, the volume in the restrictor has decreased. Okay, here also it is decreased, but is at the less pressure there is more volume here in the obstructive, but in the more pressure there is less volume in the restrictive. Good. And all the parameters we have discussed in emphysema and bronchial asthma. This is in brief. You can just look at it, look at this slide, and you will easily understand. Okay, in spirometry in bronchial asthma, see this, in bronchial asthma in spirometry, obstructive pattern is reversible with short acting beta agonists, right? That is why the asthma will reduce with the nebulization and all that. But in emphysema, reversible obstructive pattern on administering SABA. Okay, very good. And see, in bronchiectasis, this is the important point. On spirometry, there is obstructive pattern with decreased FEV1 to FVC ratio in bronchiectasis. Okay. And in restrictive lung diseases, we have seen all lung volumes will be decreased because the lung cannot expand. Short and shallow breaths because the lung cannot expand. And again here, the numerator and the denominator concept we have discussed earlier. And these are the few parameters you have to know. It is a cakewalk for you if you easily see that. See, FRC, functional residual capacity, has increased in obstructive, right? And total lung capacity is increased, right? Because of the air trapment in obstructive. And in restrictive, air is not going inside, so it cannot be trapped. And see here, the one we discussed, FVV1 to FVC ratio, this is normally it is 0.7, that is 70%, and the obstructive it is decreasing, right? And in restrictive it is normal or increasing. See, but mostly it is it increases, we take it as it increases. It can be normal also. Okay, this is how we have to see all the graphs. And this one, in obstructive disease, FEV1 to FVC ratio less than 7. This is important. This entire table is important. FEV1 is lower, that is 30 to 35% only. Okay, in severe disease. Other lung volumes, residual volume is very high in obstructive. Take it as emphysema or bronchial asthma. The residual volume is very high due to the air entrapment. And in restrictive, it is usually more than 7 or high, that is increased. Functional vital capacity is low. See, forced vital capacity is low. As we have discussed, the lung cannot expand, so air cannot enter inside. Residual volume is low. Inspiratory reserve volume is low. All the volumes are low in RL. This last statement you do please remember. In obstructive disease, the FEV1 is reduced is due to increased resistance, right? Possibly even complete obstruction of airways. That is good. That is air trapment. During expiration, that is air trapment, right? That is what we have discussed. In air trapping can also occur where more air is inspired than expired, which can cause the residual volume to increase. In asthma, obstruction is reversible which aid in the diagnosis. This means FEV1, FEV will recover on retest after application of bronchodilator. Actually, this method of testing the FEV1 to FVC ratio is very good in follow-up of the bronchial asthma cases after medication, after treatment. Okay, very good. And there is an important point about the transpulmonary pressure. Okay, this pressure is used for positive and expiratory pressure, PEEP ventilation. Okay, or PPV, positive pressure ventilation on ventilators. It is used to determine how much pressure you should put. Okay, and there is a catch here. See that transpulmonary pressure gradient, this is different. This is completely based on arterial and venous pressures of pulmonary circulation. This venous pressure is pulmonary capillary wedge pressure. Okay, this is the gradient which determines the pulmonary hypertension if it is more than 12 mmHg. Okay, it is obvious that it is more pulmonary hypertension if it is more than 12 mmHg. Okay, this is about all the volumes and curves that you need to know. Just refer to different books, and I think you can solve most of the questions, and you can read most of the required graphs that you are given. So finally, thank you.